Hello and welcome to Drake University Student College of Clinical Pharmacy's clinical update on treatment and prophylaxis recommendations for measles. This information is based on an early release from the Committee on Infectious Diseases for the Red Book, which is published by the American Academy of Pediatrics. Measles has gained a degree of celebrity recently due to an ongoing outbreak in the United States, particularly in California. As measles is preventable and cases have declined by more than 99% since the introduction of measles vaccination in the United States, this outbreak is rather alarming. Further, considering that measles is among the most deadly of childhood fever illnesses, it is important that pharmacists are familiar with pediatric measles management. We'll begin with an overview of the clinical presentation of measles, along with some additional background information. Measles typically presents initially as a prodromal high fever with cough and bluish-gray spots on the buccal mucosa, referred to as Koplik spots, followed by a diffuse maculopapular rash appearing 1 to 3 weeks after exposure. Complications can occur frequently in measles, particularly in children, including upper respiratory and ear infections, diarrhea, and in about 1 of every 1,000 cases, acute encephalitis, potentially resulting in permanent brain damage or death. Measles is caused by a morbillivirus of the family Paramyxoviridae, with humans as the only known host. Measles is very highly contagious and is spread most commonly by virus-containing droplets. Approximately 9 out of 10 non-immune people who come in contact with an active measles patient will contract the disease. Patients are contagious from 4 days before the appearance of the rash to 4 days after its appearance. Most rashes will appear within 1 to 2 weeks post-exposure. Next, we'll discuss how measles is treated. Unfortunately, there is currently not an approved therapy for measles. However, laboratory-based studies have shown it is susceptible to ribavirin, and this has been used with some success in immunocompromised children. Vitamin A megadoses have been shown to reduce overall mortality in children with measles infection, and they are recommended by the World Health Organization. 2 doses are given with specific dosage dependent upon age, as is shown on the screen. While vitamin A deficiency is a relative rarity in the United States, it is nevertheless noteworthy that children with signs of deficiency should receive a 3rd dose of vitamin A 2 to 4 weeks after the first 2. As mentioned, measles is highly contagious, and confirmed cases should be isolated with airborne exposure precautions. These precautions should last until 4 days after the rash has appeared in otherwise healthy children. However, for immunocompromised patients, airborne precautions should be used for the duration of the illness. Ideally, anyone who is not vaccinated should be excluded from institutions where measles patients are being treated until 3 weeks after the onset of rash in the last case of measles. However, if susceptible patients are exposed, they should also be isolated with airborne precautions from 5 days after the first exposure to 3 weeks after the last exposure. Now we will discuss methods of controlling the spread of measles in an acute outbreak. The MMR vaccine can be given up to 72 hours post-exposure for those who are at risk of infection, which includes children who have received only 1 dose of the vaccine. This is ideal for school and daycare-based outbreaks. IV immune globulin can be given within 6 days of exposure to those who are unable to receive the MMR vaccine or whose immune system may not be able to fight off infection, such as unvaccinated pregnant women and severely immunocompromised patients. It's important that all individuals working in an institution where measles patients are being treated, including students and volunteers, be vaccinated. Next, we will discuss prevention of measles infection, namely with the MMR vaccine. Vaccines for measles are given in combination with mumps and rubella vaccines. Vaccines that cover only measles are no longer available in the United States. Patients must receive 2 doses at least 4 weeks apart, which provides up to 97% immunity. Patients must be at least 12 months old to receive the first dose of vaccine, and the second dose is typically given between ages 4 and 6. In some cases, patients may receive doses of MMR vaccine outside of these age ranges. Many colleges require evidence of MMR vaccination or immunity, and if outbreaks occur, MMR vaccination should be offered to patients older than 12 months without evidence of immunity regardless of their age, and may also be offered to infants ages 6 to 11 months to provide some protection against infection. However, the 2-dose schedule must still be completed in this case, as infants have lower seroconversion rates after vaccination. Children ages 6 months and older who have not yet received a dose of MMR vaccine should receive 1 dose before international travel. Patients 12 months old or older who have already received the first dose more than 4 weeks prior should receive the 2nd dose before international travel if possible. A potentially high fever is the most common side effect of MMR administration and can rarely lead to seizures in about 1 in 3,000 to 4,000 patients. Rashes are the next most common side effect after high fever, occurring in about 5% of patients. Thrombocytopenia is a rare side effect occurring in less than 0.01% of patients. It's important to note that side effects typically occur in patients receiving their first dose of vaccine, not with subsequent doses. While encephalitis and encephalopathy have been listed as rare adverse events, their incidence with MMR vaccination is actually less than that of idiopathic encephalitis. Thus, it's difficult to determine if these occurrences have an actual causal association with the vaccine. However, there is a litany of evidence refuting the notion that the MMR vaccine can cause autism spectrum disorders. Patients with minor illness-related fever can still be immunized, as can patients with egg allergies and allergies to neomycin or gelatin, which are not severe. However, those with anaphylactic reactions to neomycin or gelatin should not receive the vaccine. Additionally, immunocompromised patients should not receive the vaccine, with the exception of HIV patients who are not severely immunocompromised, and I'll discuss that in just a moment. Immunocompromised patients who receive the vaccine should receive immunoglobulin, as they may develop an active infection. Severe immunocompromisation in HIV patients is defined as a CD4 T cell count less than 200 cells per cubic millimeter. Administration of vaccine in these patients can cause pneumonia and must be avoided. However, for all other non-immune HIV patients, the vaccine may be given at a normal schedule. The vaccine may increase the seizure threshold. However, this is generally not a reason to withhold the vaccine. Pregnancy, however, is an absolute contraindication to MMR vaccination due to a possible risk of infection of the fetus. Patients who present with signs and symptoms of measles should be reported immediately to public health officials, with subsequent vaccination of all eligible individuals without evidence of immunity who are at risk. Serologic testing for immunity is not recommended, as extra doses of the vaccine are not associated with additional adverse events and are much more prudent in an outbreak than testing for immunity. In order to curb the spread of infection, those who are unable or refuse to vaccinate should be excluded from schools, child care centers, and healthcare institutions until 21 days after the onset of rash of the last case of measles in any of these locations. This concludes this presentation on measles treatment and prevention. For more information, please see the link on the screen, which is the full-text Red Book update. And for further comprehensive information on measles infection, please see the CDC website. Thank you.